So our next panel is entitled Narrowing Down on New Jersey. And I am honored that we have with us really leadership across many of the spectrums of the healthcare stakeholders that are impacted by a lot of the issues we've been discussing so far today. On my right, your left, we have Betsy Ryan, who's the CEO of the Hospital Association, Ward Sanders from the New Jersey Association of Health Plans, Larry, perfect on cue, Larry Downs from the Medical Society of New Jersey, Jack Sullivan from the New Jersey and soon to be the Northeast, rather, Carpenters Fund, possibly the only person in the room who's actually making these purchasing decisions every day. Other than individuals, and Senator Joe Vitale, who is, as many of you know, the preeminent leader in healthcare policy in New Jersey and is chair of the Senate Health and Senior Services Committee. So thank you, all of you, for agreeing to participate in this discussion. I invited all of our panelists now to speak to all of us for about 5 minutes or so based on what you've heard from national speakers, looking at the goals of both affordability as well as quality. What principles do you think are necessary from a regulatory standpoint or a policy standpoint to achieve the promises of the Affordable Care Act when it comes to the product offerings and networks that are being offered across New Jersey moving forward? And so we'll start with Betsy and move our way across.
Thanks, Linda. I actually do make purchasing decisions on behalf of our employees, and I won't tell you who we use, but they recently made a decision to tier some providers in New Jersey. So we have struggled with this issue at the New Jersey Hospital Association. We're a trade association for any of the students in the room that represent all of the hospitals in the state of New Jersey, along with post-acute care providers, 300 plus. And so obviously, when some of the recent policy decisions came down, we wrestled with the issue, having so-called winners and losers on both sides, which seems to be the story of a trade association executive's life. And what we did is what trade associations do so well. We formed a task force to study the issue. But we really did a deep dive into it in a very time-constrained manner, and it was my officers, the executive committee, and we added a board member from Southern New Jersey, because we always strive to have geographic balance, very important in the state of New Jersey. And we came up with 5 principles that I'll take you through that we think any public policy around tiering should consider. And when I presented these 5 principles to my board, we asked them to do 2 things when considering them. One, try to find common ground. And secondly, as was mentioned by the prior panelists, we thought it was important to remind them that your tier of today might not be your tier of tomorrow. So when you think of what should be considered, you should keep that in mind. So here are the principles we came up with. And the first one is basically an endorsement of the triple aim that we strongly believe in improving quality of care and patient safety, maintaining access, and providing care at the lowest cost. The second tier really gets more into it, and that is that patients should be held harmless and not forced to pay more than the lowest cost tier in an emergency situation. There was a strong feeling that you needed to look at this through a patient's eyes, and I remember the board discussion, some board members saying, do you really want a patient who needs emergency care to be thinking in his or her mind, ooh, I can't go here and I'm in such pain, I need to keep driving. So that was an important principle. Third principle has to deal with the insurer responsibility, and I know one of the past panelists towards the end mentioned this, that the insurer should be held responsible for providing adequate, accessible, and timely information and education about a limited or tiered network so that the patient and consumers are fully informed in areas such as access to providers and out-of-pocket costs when seeking care within the limited network or when going outside of the limited network. So putting some responsibility on the plans to really provide information on the implications, good and bad, cost sharing or not, in terms of tiered networks. The fourth one, and I'll look to my former colleague, Commissioner of Health, Heather Howard, because she'll get a kick out of this one. We thought that, the Department of Banking and Insurance, or DOBI, as we finally call it here in New Jersey, needs to update its regulatory framework for review of the limited networks before a plan is certified and marketed to the public, and that DOBI should look to its sister agency, the Department of Health, which we feel has a far better understanding of the healthcare provider network in the state of New Jersey to ensure that access to care is maintained for all New Jerseyans. And then lastly, and I'll close with this, deals with transparency, which many of the panelists have touched upon, that the factors and criteria used to profile providers and place them in tiers or limited networks should be transparent to regulators, beneficiaries, and the providers. I know from talking to many of the hospital CEOs in the state, they're not adverse to tiering. They just want to know what they're being judged on, so they want transparency. So they were the 5 principles we came up with, and look forward to hearing from the rest of the panel.
Great, thank you. And I am keeping a Venn diagram here, so as I see overlap, I'll just hand that over to Senator Vitale so we can get to work. Ward.
Sure, thank you. I have 5 points for 5 minutes, and you gave us 5 minutes. A couple of preliminary points, too. First of all, thank you for the Healthcare Quality Institute for inviting us to attend Princeton today. This is the only way I was going to attend Princeton. Second, when we talked about it, Mr. Ario and others really laid out a sort of federal landscape and did a fantastic job. I learned so much from all the presenters today. It was great. I do want to make reference, though, that as we drill down into New Jersey, not to forget that much of the Affordable Care Act and our regulatory climate was driven by Governor Florio's reforms from 1992, which were largely successful. Some novel experiments in the individual market, which didn't pan out, but it was really because of a lack of funding for subsidized coverage. So a lot of what we have, by the way, we do have standardized plans in New Jersey and have had since those 1992 reforms. It's referred to as a sort of a muscular regulatory policy. They really have a long history in New Jersey of that. Number 3, I did want to thank former Commissioner Howard for introducing me to the concept of insurance stick, or insurance sticking. And hopefully we'll have some qualitative measures and quantitative measures around that. And then lastly, I do want to say that there has been some tension around issues related to tiering. But as we delve into this, I want to not forget and remind folks that, as I talk to my colleagues in the insurance industry and friends in the hospital industry and physicians, that the level of collaboration and dialogue and trying to align incentives in the past couple of years is so much better and more intensive than it was 5 or 10 years ago. So it's important not to forget that. On to my 5 points. The one thing I wanted to start with was to remind folks that tiering is a result of consumer and purchaser demand. And insurance companies want to offer high quality, high value plans with robust networks, and that's the product that they sell. That's what they compete on. We've had an individual market in New Jersey that didn't compete on risk segmentation. It's an all coverage market. But we keep hearing from our members and the people that are purchasing coverage, and as a purchaser for a small association, we felt this too, is that the cost pressures are hugely important in this, and that both before the Affordable Care Act and after the Affordable Care Act, that cost remains sort of the biggest and largest barrier to access to coverage. We still have a lot of folks that are uninsured even after the benefits of the Affordable Care Act. Consumers are calling for lower premium options and lower cost-sharing options. When you look at the healthcare dollar and the claims portion of that, over half of it, or close to half of it, I should say, is related to hospital expenditures. So it's not surprising that tiering is happening. As we've heard this morning, or early this afternoon, it's a national response, and we've certainly seen it here in New Jersey as well. Number two, accelerated by the Cadillac tax. It's been delayed from 2018 to 2020, but that was a huge influence on motivating purchasers to say, you know, we're going to get a 40% excise tax above a certain level, and we're going to get nothing in return for it. The state health benefits program was scheduled to get $261 million in taxes in 2018 and $837 million, almost $1 billion by 2022. So there's an extraordinary pressures on the cost end, and that would have done nothing to improve care. It was really just a tax. The notion of tiering, too, that I think is important, and I want to make sure that we don't jump into a regulatory scheme that really thwarts this or limits it here in New Jersey, and that's really my theme here, is that tiering does improve access to coverage. Our small group market used to cover 930,000 people. It's down to 475,000. Enormous cost pressures in that market, and we've seen, you know, a really plummet in size in the last 10 years. Individual markets have been propped up through the subsidies, but still challenge around affordability. There's a lot of people that are churning in and out of that market that are just able to afford it or just not being able to afford it. This keeps those people, those small employers, in the insurance market because it offers a price point that they can actually afford. So I think it's important. If you have somebody who's uninsured versus somebody who jumps in and can afford a tiered product, that's not only good for Tier 1 hospitals, Tier 2 hospitals, it's also good for uninsured or non-par hospitals. An insured life is better and is going to pay for services in a way that somebody who's uninsured cannot. When the individual and small group markets under Governor Florida's reform started, we had a $2 copay plan. Can you imagine that? There's nothing that resembles that, even close to that. And we can't keep trying to solve this through increasing the cost share. This is a nice alternative option to those high deductible plans. And most importantly, the question that was being teed up here is to level set for New Jersey. So we saw the map earlier today of the states that have quantitative measures for network adequacy, and that was held as the gold standard. Bless you. New Jersey is one of those states that has had for a long time quantitative standards regarding access, time, and distance measures for a range of services, including hospitals, emergency services, and so forth. It's not just for HMOs, it's for all licensed entities selling coverage. I know some states don't have that, or it's limited by a license. And New Jersey, while its regs probably haven't caught up to the modern marketplace, the Department of Banking and Insurance has interpreted its rules strictly to say, we're not going to look at access in terms of both Tier 1 and Tier 2 hospitals and see what access consumers have. We're going to make sure that those standards that we've had in place are met by just Tier 1 providers. So as we think about a regulatory scheme, I think we want to start with this notion that we're not starting with a blank slate. It's not like there's nothing there. New Jersey has some pretty strict quantitative standards around network adequacy. It's, you know, for the insurers to see this, so the others don't, but it's an iterative process with the Department of Insurance. There's a filing, it's vetted, there's pushback, there's questions, there's modifications. It's a dialogue that goes back and forth in this process. And that process exists. Lastly, I wanted to end on a cautionary tale. Is, you know, 20 years ago, 25 years ago, the insurance that everybody talked about was auto insurance. And we evolved into a state that had, you know, I think most observers would agree, was an overly regulated market. It led to the departure of many insurance companies. There was a lack of competition, and you know, with the relaxation and some sort of smarter regulatory construct, we started to see insurers come back in a more competitive marketplace. I think as we look at tiering going forward, we need to look at what the problems are, if any, define them, and think about a solution that not only are well-intentioned, but would actually attempt to solve, or would actually successfully solve the problem. Our fear is that if you go in and say, try to standardize what the formula is, you will create a winner class of hospitals and a loser class of hospitals, to the detriment of a lot of really good hospitals in New Jersey. That some marketplace dynamics are probably better than trying to mandate or regulate what that costs.
Thank you. So next, Larry.
Okay, we're going to get your red pen out for your Venn diagram. Thank you so much for having us here today. I have just a couple, you give us 5 minutes, everybody has a 5-point plan, so I'm going to try and get away from that. And I do want to react to a couple of comments I heard on the earlier panel on both network adequacy and physician leadership on quality issues. Those are 2 important carryover topics that we should discuss. I think it's safe to say that physicians have significant interests in how third parties like insurers and even consumers rank their performance, particularly on quality measures. And these aren't new issues. The Medical Society of New Jersey, much like the Hospital Association, a trade group of MD and DOs around the state in all specialties. And we have some of the same issues that Betsy had articulated earlier that are inherent in a professional organization of varied interests, particularly when you look at every single medical specialty. Many have different conflicting issues. However, back in 2008, United Healthcare came up with the first attempt at ranking physicians called the Premium Designation Program. You may remember those terms. And at that time in 2007 and 2008, the Medical Society convened a multi-stakeholder group, physicians from all different specialties, and looked at some policy statements around physician ranking or its first cousin, tiering. And many times physicians will use terms like physician profiling and things like of that nature. And the AMA, the National Organization, and the Medical Society both have policy statements from 2008. I'll spare you reading the dense AMA policy, but I think the most interesting sentence in it, I'll read from here, is that the AMA strongly opposes the use of tiering and narrowed physician networks to deny patient access to or attempts to steer patients towards certain physicians primarily based on cost factors. And I think that's the issue that physicians most object to or surmise, that tiering and ranking programs are only economic and there's no quality aspects to it. I think that in the MS&J statement, we've made some observations about these programs. And basically, I'll read the one, I think, penultimate paragraph here, that given the inherent tensions in physician ranking programs, they must be carefully scrutinized to ensure they are accurate, fair, transparent, and understood by all stakeholders, including patients, physicians, employers, providing healthcare insurance, and regulators. And subject to independent review and oversight, these systems should truly promote quality of care for patients and improvement in performance rather than merely cost savings for insurers. So you don't hear in there that we have objected as a medical society to any kind of ranking or tiering. We just want it done correctly. And that brings me to the statement on the first panel that physicians need to lead in this area. And I would press back a little bit. The physicians are anxious to lead in this area, but it's only been recently that individual practicing physician practices have had the resources to actually gather their own data, to look at their own performance metrics with the advent of certain quality clinical data registries and other things coming out. Medical specialty societies are actually collecting and reporting on the clinical data and measurements that they find relevant to the care of their patients. So I think we're going to begin to see, particularly in some specialties like cardiology and ophthalmology, and spreading to many other specialties, reporting, public reporting on these issues. And as a medical society, we're supportive of that. I think the network adequacy, which kind of goes hand in hand with this, our position on that is that there are very good network adequacy requirements in place, as Ward has pointed out. Our issue is that they're not regularly enforced. As in any state, there's manpower shortages, there's many competing priorities, and getting adequate networks audited and looked at by state regulators, sometimes it's more than just the regulations on paper, it has to actually be done. So one of the things we were very encouraged by is legislation that was introduced shortly after we put together some of these policy statements, was introduced. Bills by Senator Vitale and others really looked at making sure that we're adequate and transparent networks that were based on quality measures that were real patient outcomes to the extent that they were possible. So we're very encouraged and supportive. Our physicians are more than willing to lead on clinical quality discussions and willing to partner to make these things happen in the short term. So with that, I'll yield the balance of my time to Sullivan.
Thank you, Larry, and I'm going to wheel mine over to Joe, and I'm short as well. I find it an interesting name, Fears of Tiers. I've been with the Carpenters for 30 years, and we've been crying tears for 30 years on the cost of the government. So, and to go with someone said in the back, it costs, as a purchaser of coverage, you know, cost, it's not that cost drives us to make changes. When our cost gets to be where we can't provide the benefits anymore because they're becoming too expensive because cost is going up, we need to make changes to the program. So I've been in this position to steer our health plan since 1992 and through all the waters and try and keep it afloat and in the best direction we can go. So what are the, in looking at this, cost is what drives, I know it hasn't come out today, but you've heard the old adage that 20% of the people push 80% of your cost in your plan, or 10 for 70, or whatever, a very small amount drive the high cost. So those are the people that we want to keep our eyes on. Those are the people that have multiple chronic conditions. Those are the people that you need coordination of care with. The the accountable care organizations, the patient model homes, these tiered programs, the way they're coming out, saying they're going to provide this coordination of care and quality of care. Those are the things that we look for in a carrier who's out there, or a program or an ACO or patient model home that's out there. If someone can provide that and show that you're driving the cost down on those patients, is something that's going to be very interesting to a plan like us or anybody else. What we do, because we don't see that that's there yet, they're new, there's been pilot programs, there's statistics that are starting to come out, but with numbers, I'm a numbers guy, you can make numbers look any way you want. Some of these programs that have come out have said, well, yes, we can see in the numbers, we've done this, emergency room visits are down because we manage this patient better. They're not coming through the system over and over again. Well, is it that emergency room visits are down, or are they not emergency room visits anymore? They're now called observation stays. So you shifted it over there. So there's ways to play the numbers game all over in everything, pharmacy, the whole realm of healthcare. So we're kind of skeptical at the Carpenters with joining these new programs, even the wellness programs you've heard over the years that they can save 6 to 1 on your money, 5 to 1, 4 to 1, and now they don't save anything. So who's been paying X amount per member per month all these years? Have you really saved anything, or have you just spent more money? So we need to see the Carpenters Fund or a plan like us should need to see proof in the pudding. So once these things come around and we can see that yes, these models are great and whatever, I think it's really going to drive people there, and it's going to improve care, quality care. Just to cost again for a second, it's crazy how you can get an MRI in one place at $400 at a freestanding place, but then we'll see a hospital bill where we're being charged $8,000 for an MRI or a CAT scan. you know, it makes me think, are they magic beans? Are they magic grits? Do you know, like the movie My Cousin Vinny, these things should be comparable. Why is one thing here and one thing here? So it gets to be an issue where we're trying to steer ourselves the best we can. We want our members to have access to care, no barriers. We do not have any deductible up front. We have front-end dollars are covered. We are trying to get them to the providers when they need care with no obstacles in the way. We encourage screenings and all those things to happen. And we were approached with these tier networks also. The problem there is that you know, we would never go for something like that because in some of these tier networks you can't have an out-of-network benefit. Well, we need our members to be able to, if they like their doctor, we had a question before and they want to stick with their doctor. Well, you can stick with your doctor. And you'll know what the program is, and it's very hard to get people to change if they want to stick with their doctor. They can, and it's an out-of-network benefit. Some of these tiered networks, as they're tiering down narrower and narrower, there's going to be more out-of-network with that group. So you're going to have more out-of-network bills, more out-of-network surprises that you know we're always trying to avoid, and that is an issue for the Carpenters Fund. Even though we have a very generous benefit, we've had to cut things like dental or vision, but as far as people's health care and what's out there, we really believe we have a great program that does break down the barriers, gets them access to the care, but you know, we do have these out-of-network issues where if someone goes to an emergency room, they cut their hand, and we had one the other day, a spouse cut her hand on the kitchen sink, she went to the doctor, it was $15,000, because they called in a specialist participating in network hospital, but the doctor that got called in was out of the network. And you know, our reimbursement on that, we reimburse when it's out of network at X amount, it's 20% above the Medicare rate. I mean, that's not gigantic, but it's better than Medicare rates. And that was $2,500, left a balance of $12,500 that the patient got. And they came to us. Now, legally, we have no responsibility there, the fund, but as a fund and politically, we're not going to let that happen to our members. So we're going to get in and try and negotiate that bill and make it go away for them. So yes, it's more costly for us, and that's an example on a very low level. It happens all the time. If it's a brain injury or brain bleed, the bill's not $15,000, it's $150,000. And then the payment's $20,000 by us, and there's $130,000 out of pocket. Out of network. So there needs to be some accountability for some of the charges and you know, what the Carpenters would love to see are these ACOs, really, or patient model homes, and these tiered networks to come up with these things where you always thought, and we talked about the HMO years ago, the HMO guy, your primary person was supposed to be your gatekeeper, someone who knew everything, every doctor you went to see, and it just didn't work like that, unfortunately, but we need someone, the team, to be responsible, someone in the team to be responsible for that person's care, that the 10% that's driving 80%, because the other people are healthy and not costing you a whole bunch of money. It's the chunk of 20% that does, that really needs a coordination of care and a team to make sure, and that team around them, they need a lot of cooperation amongst them. That's hard to do. All those different providers and services need to coordinate and cooperate with each other. And a lot of times they need to wrap around a mental health piece, which isn't in there, where, you know, because that person has all these chronic conditions. It's a tough thing to do, and we'd love to see it come to fruition, which is what people are trying to do, so I applaud the efforts to get there.
Thank you. Senator.
Thank you, Linda, and thank you for the invitation and for all who have attended and had the energy to stay until the end. And also want to just talk about a little bit about how we can, some of the successful things we've done in terms of collaboration in New Jersey. And I was thinking a little earlier when I worked with Betsy and the Hospital Association several years ago on the Patient Safety Act. And that was, took a while, that was a couple of years of discussion. And remember Cliff Lacey, the commissioner at the time, sort of locked us in a room He was there as well, didn't let him leave. But he didn't let us leave either, and until we really talked about how it is that we can come to an agreement to protect patients, to allow hospitals to have those internal patient safety discussions, and at the end of the day, provide for a reduction in medical errors throughout the hospital system. And so there's a way we can collaborate and get things done in New Jersey. You know, we're still struggling with the out-of-network issue, which is awful for patients, for consumers. They are caught in the middle of two interest groups where a lot of money is involved. And so we're still trying to work with those issues, and I know that we'll solve the out-of-network issue in New Jersey soon. As I listened to the national panel and the keynote speaker, it was great. It was very informative and helpful for me and for many of us here. And just how complicated it is, and how complicated we've almost made it, it seems. For all the smart people in this room, and you all are, maybe it's not that complicated. But for consumers who are trying to work their way through this issue, it's nuts. It really is. You know, listened to a report the other day on radio, and 26% of enrollees in the bronze and silver plans have no idea what they have. They know they have a plan, they know they have this sort of network, and they're completely clueless, and not their fault, about out-of-network and network. 26%. And I don't know what the other 74% think, or how much they understand it. You know, if you're all in it somewhere, you sort of get it. It's so complicated, and so, you know, that's not a solution, it's just an observation. And I think it's kind of hilarious that we haven't mentioned the O word today. You'll get it. And it's only to illustrate sort of maybe in part why we're here today, that, you know, the tiering issue came up recently in hearings and in litigation, and so Senator Gill and I had a joint committee hearing with Health and Commerce and try to get to the bottom of what this new tiered product looked like, acknowledging that tiering has been here for a while already with other plans. But it sort of became the issue of the day when it was that, you know, providers around the state hospitals and other physicians and others had been sort of carved out in their view of the process and given sort of second tier status. And when I think about the impact it has on consumers, and one of the questions that we asked at the hearing was, what happens when someone who is a member of this new plan, and through no fault of their own, they're walking down the street, a brick falls on their head, and they have to be taken to the nearest emergency room. And we have random tower laws here in New Jersey, so you go to the emergency room and take care of it. But if you have to be admitted, or if that's a stroke or a heart attack, or some other event where you're incapacitated, you're going to go to a hospital no matter where it is, and if it is, whether it's an Aetna plan or a Horizon plan or some other plan, and you go to a Tier 2 hospital for the emergency, you're treated in the emergency room as a Tier 1, and so all the benefits are the same, there's no additional exposure. But if you're admitted because you will probably be admitted because you had a stroke or a heart attack, or you're unconscious and there's a big crack in your head from the brick, you're going to be subjected to now the Tier 2 cost chain. And so the point is that I don't think that's fair. And two, you know, if you did have the choice, you were conscious in the ambulance, do you have the wherewithal to know that, gee, don't take me to St. Francis, please take me to Princeton. Or please don't take me to wherever, JFK, take me to Robert Wood. And then you would know that if you were admitted, then you're not on the hook, you're on the hook for less or very little cost share. Whereas if you're in the other situation, you're probably where you were when you had the other plan, or maybe it's more likely in some ways, but is that a fair thing to expect of a consumer when they're trying to access care in a convoluted, complicated, crazy world of healthcare delivery, where we looked at all the slides and they're great, but imagine sitting 200 people in this auditorium, the average folks from the street, they'd either fall asleep or they would just know what the hell we're talking about. And so I think that what Senator Gill and I are trying to do in a very sort of thoughtful, comprehensive way, working with all the stakeholders, is to when we're talking about tiering and we're designing tier products in New Jersey, is there has to be a level of accountability and transparency and understanding. And so and some of it we worked off the New York model, right? So there was an agreement in New York between Cigna and Attorney General Cuomo at the time that established a certain criteria for tiered plans, how they're reported, how they're designed, who can see them, what they understand it to be, and so it is that people have a greater understanding of what this looks like. I also think that in a tiered world, there has to be an acknowledgement of what it means to the products or to the providers, whether it's physician groups or hospitals in this case, relegated to a different status and level. Because it is, and Lee was great on this, and Leapfrog, and that there are higher tier products who have scored lower in Leapfrog, and lower tier products or hospitals that have scored higher in Leapfrog. I thought it was about quality. Not only quality, but I thought a lot of it was about quality. The quality seemed to be in third or fourth place, and not an honest debate about what quality actually looks like. And so I think part of these, one of these bills will, we hope to address that, so that there are real quality numbers, that the metrics we use to establish what are better tiered providers are really accurate. And if you want to drive people to lower cost, higher quality hospitals, God bless, great idea. But in the meantime, we have this sort of strange contradiction, for lack of a better word, where you have hospitals that have been, up until recently, whether it's Cigna or Horizon or another, or Aetna, full-fledged members of their plan, right? In-network, maybe their reimbursement rates were different because of the size of whatever the negotiation was, but they were all in-network. And now, because of the tiered products, well, in the most recent one, they're all still in-network, but the higher tiered are treated differently than the second tier. And the tiered product, the tiered process was, I think, not done well. But now they're sort of like tiered like. I mean, they're sort of like, you're in network, but you're sort of like 1 foot in, 1 foot out. You're treated as though, in some ways, as you're almost out of network. You can still go there, consumer. And by the way, and I'll close with this, if I didn't want to make this about this plan, and it's not. It's about all tier products that we have to be mindful of, which is that when someone goes to that hospital in an emergency, and their cost share is different because they did nothing other than have a significant medical event, and that's not good. And then the last piece of this is the promise to the upper tier hospitals. I mean, this happens across all tier products, all plans, that we're going to reduce your rate, which hospitals aren't crazy about, but what's the trade-off? What do we get for that? You're going to get volume. That's a good thing, right? Because we only have a finite number of patients in New Jersey. Where are they coming from? Well, likely from those other lower tier hospitals that people will not be incented to go to because they will cost them more money. And so we'll go here. And so therein lies the problem with safety net hospital access for low-income, uninsured people in hospitals, not all, but many, who have gotten sort of this lower tier status. And so we really have to be careful about what we're doing and the impact that it has on consumers. Insurance companies, God bless, do that they have to do. Providers do what they have to do. There's always a struggle about money. But in the end, whether it's out of network or it's the tiered products, you're really mindful of the squeeze on consumers, not in terms of access to the right patient, the right provider, at the right time when they need them, but also the cost. Because for so many of them, cost is everything.
Thank you. I want to go back. I want to take you back to earlier today when Joel was talking about sort of the Achilles heel potentially of these plans, and talking about, and then Leah picked up on it with the HMOs, and that if things are just based on cost, there's certainly a risk of a consumer backlash. And so it was put forth that quality, must be a big part of designing these plans. But you all have raised a lot of different definitions of quality, and I think throughout the day, a lot of different definitions of quality. have been raised. Certainly Leah talked about Leapfrog, safety score, and how they look at hospitals, but Jack raised the importance of ACOs and patient-centered medical homes and continuity of care for patients. So I'm actually going to put Larry in the hot seat first. I'm curious, when you're all talking about quality, so to speak, really what factors are you looking at? And also, particularly since physicians want to work towards those factors too, and also what role does transparency versus what could be considered proprietary in designing a network or a plan come into that?
Well, let me start by saying, many of the criteria that are used to tier or rank physicians are secret right now. We don't know what they are. Certainly the consumers buying the products don't know what they are. And it's really hard to lead or have a discussion when the criteria with which you're tiering or ranking is not made public. So we can have an argument about what the appropriate clinical quality measures are if we know what they are. And right now, so I think the first step is to make sure that whenever we're talking about a limited access network, how that network was established, I think is important for me as a consumer, because I want to know, is that just a cheap network, or are there really good doctors there? Or how did you manage to arrange these physicians into this tier or into this program? So I think number one, the criteria should be at least clear and understandable by the public who's purchasing, and certainly the physicians. I think physicians and hospitals relish the ability to compete. I know doctors do. A very competitive group, would love to compete on their quality. Highly trained, highly competitive group as a demographic, and I don't know one doctor that wouldn't say, I'll put my quality up against the next person as long as we're measuring it correctly, and we all agree what the terms are. So what we think there should be in terms of a quality outcome is at least some patient outcome. If it's an orthopedic procedure, maybe it's range of motion, maybe it's the ability for the patient to get back to work, like some kind of quantifiable patient outcome that everyone agrees is an important one. I think that patient satisfaction, and we touched on it earlier, folks, physicians are being ranked right now every day on things like Yelp and Vitals and health grades, and whether they like it or not, any one of us who goes out to get a service, whether it's an airline or a hotel or a B&B in Vermont, we're going on to Travelocity or some kind of rating, Google, to see, what do other people think about that. That's happening right now in the physician world, whether the doctors are comfortable with it or not, but they're doing it basically on patient experience. So as you heard from the first panel, there are some quantifiable ways and some research that says people have great experiences, have better outcomes. And so something in the patient satisfaction world would also be something that we think should be included when you're ranking or tiering or calling a network a high-quality network. So, I mean, those are the kinds of things that we're thinking about. And as I mentioned in my statement, with the advent of the merit-based incentive program through CMS, there will be required reporting on clinical quality in order to avoid penalties in that program. So we're starting to see lots of state medical societies and specialty societies put together reporting programs that should lend themselves to generating at least some quality data that can be used in these efforts.
Well, I think it would be important to, and we did receive part of the NIRE report and see what the recommendations are for the template in terms of what else. Also, we can maybe layer over what we're providing to that degree. So the way in which let me just give you an example of why we need to have a way in which to rank and score and whatever the providers are going to be in the upper tiers. And then I'll let Leslie just touch on are we tiering properly. But a recent testimony suggested that the tiered products in New Jersey were decided upon by CMS data, quality measurements and outcomes, and patient satisfaction from polling in U.S. News and World Report. So when I asked about leapfrog being sort of the gold standard, or the standard by which we should judge hospitals in particular, the reaction was, well, that's not their thing, which is not true. CMS has decided to drop, they're going to be in that business next year. And so, we're not going to use CMS data. What data are we going to use? How are we going to score providers and doctors and hospitals in terms of quality? Leapfrog's a great way to go. Maybe that should be named Leapfrog, but there has to be a methodology by which we can honestly score these patients. And lastly, and I've had this discussion with friends in the industry on both sides of the issue, that plans have decided on this tiered product, and they're winners and losers. If you're tier 1, you're a winner. If you're tier 2, you're a loser. No matter what you say, you get a scarlet letter, you are tier 2. 1's better than 2. Right? If this were, right? It is. So, what's yelling like, we want to be number 2. So, we're number 2. So, if we had a scale of 1 to 10, and you were 1 or 2, that's good. But if the scale model is 1 to 2, then you're a 2, then you're a loser. Right? In the eyes of many people, and we've been hearing this around the state. And not just, sort of anecdotally. But why is it that and we all want to drive up quality, drive down cost, and the wrong kind of cost, right? The inadvertent cost, the repeated admissions, all the mistakes and errors and whatever, we want to drive that down. And treat your frequent flyers with the Brenner model, all kinds of different ACO models, and get that working in the right way. But why is it that we can't say to every hospital, if you perform at a certain standard, you provide services and outcomes and quality measurements that meet these benchmarks, everyone gets rewarded. Now, it's a slower process, I think, right? Because you're not driving patients to different places. It's a slower process. But why is it that a hospital that is called a tier 2, ranked an A by Leapfrog, going to lose volume? What did they do wrong, other than provide quality care at one of the lowest cost hospitals in the state? So it's a little unfair, a lot unfair, and so that seems that part of the process seems to need correction, because it is that, they're maybe somebody's hospital big and powerful and have kind of cachet and whatever, and at the end of the day, it really wasn't about quality selection. That was number 1. It was about, if you're a big hospital that's expensive, you're in. We want you. Drive down the cost. It makes sense to bring in an expensive hospital, try to drive down the cost. But for other hospitals who are already low cost, high quality, they're sort of on the outside looking in, and they have to now compete now. How do they keep their patients? And so one of the legislative initiatives and thoughts is to say that if you're admitted through the ED, no matter where you are, you get treated at the lowest cost to you.
So I'm going to give you more. Do you want to
Yeah,
respond at all?
I appreciate the senator's comments. And the importance of quality shouldn't be underestimated. It should be visible to consumers. We, as a state and country, have struggled with quality measures and trying to figure out what's the best way to measure this. There's outcomes issues, there's risk adjustment, and so forth. But folks are trying. There are things like Leapfrog. We are blessed in this state that we have a lot of really good hospitals. I've heard from Leapfrog, as know, family hospitals in that grade. In the creation of a tiered network, while quality is a component, there's other things that are necessitated carrier to look at other factors. So it's going to have to look, number 1, at geography. I mean, you could have a lower, ranked hospital under Leapfrog in a tier 1 rather than tier 2 because geographically, if you're required to be in the state, you have to, sort of meet those geography requirements for DOBI's standards. If it was all driven by quality, you could have some areas of the state that just simply aren't covered. Cost is we heard from our economist the earlier panel. It has to be a component. If cost was completely excluded from the equation, it would not have a great impact on the cost structure overall. And the other thing is the collaborative component of all this. the plans have rolled out a lot of ACOs in New Jersey, patient-centered medical homes, lots of partnership models in Medicare. I think we've got co-branded products with hospitals and health plans. Part of this is about relationships, who you can work with, how you can exchange information. So while quality is important, it's important for the consumer to understand the quality of the care at hospitals. The creation of a tiered network is a little bit different concept, and it requires those geographic considerations. It requires considerations around partnership models and teams that can actually work together, and a number of other factors. And I hear Senator's point. It sounds like it can be aspirational, so that there is only one tier if everyone graduates to the standards. And I guess that's one view. It really isn't a tiered product at that point if everyone is in. And that's one policy solution if that's the way you want to go. I don't know that other states have gone to that level to regulate to say that you could have a one tier. So I think we should look at these issues and be cautious as we move forward, so that we don't take away products that in many cases are the choice between, do I have coverage or do I not have coverage?
So you don't have, we can.
Yeah, I would just, comment that the policy my board adopted was not on what the standard should be, but just that the insurer should disclose the factors used to tier providers, whatever they might be. It could be leapfrog. A lot of my members believe in leapfrog. There's any number of quality factors, but whatever the factors should be, they should be disclosable to regulators, to the consumer, and to the providers competing. And I would just point out, I believe Massachusetts and Maine have legislated that.
And I think there is some language in the NAIC proposed reg to that effect, but specifically to what extent is still really where it's going to get complicated. Disclosure to what extent? How much into that secret sauce do you need to go? And I think that's one of the things that's going to be a challenge to potentially figure out. We have time for just one or two questions. If there's anyone in the audience who would like to weigh in here or has a question. If not, that's quite all right, because we actually are having a reception right after this, where you'll have an opportunity to speak with one another and ask the panelists who are still here questions. I want to ask you to join me in thanking our panelists up here today. I also just want to thank you for your attention in a pretty dense issue, but your attention throughout the afternoon. Healthcare is such a politically charged issue because it's such a personal issue, and most of us in the room today are lucky to have health insurance coverage, and with the expansion of Medicaid and the Affordable Care Act, so many more people in New Jersey do have access to health care. But I think as we think through these issues, one of the things to think about too is as we move forward and our legislature looks at these decisions, what is the impact on the system on the whole, and particularly those underserved individuals who don't have that same range of choices and services and transportation and things like that. Also, as always, the New Jersey Healthcare Quality Institute, again, is a multi-stakeholder group, and we welcome your involvement and engagement in our activities. There's information on the Institute in your packet, and we have a reception next door, so please join us, and where the real conversations happen at the after party. And we look forward to seeing you again soon. Thank you.